Okay, so I think we will go ahead and get started. I know everyone's time is precious these days. So I'd like to welcome everyone who has joined in for our call. This is the fourth session for the um, GCP study group for RQAP certifications. And I'm here with Kamala, Michael, and Pam, and I'll let them introduce themselves. I'll go first. I think, and hopefully, if you've been calling in, we're all familiar to you. But I'm Jenny O'Brien. I'm an independent GCP consultant, and been active in SQA for many years, and have enjoyed continuing my participation. And I'm excited to be part of this group because I think I've benefited a lot from my RQAP certification, and so I hope I'm glad to see others pursuing it, and we'd like to provide whatever support we can to help everyone prepare. So Kamala, why don't you go next?
Okay. So again, I'm also excited we managed to revive these study groups because they used to be active. Actually, I remember being with Jenny as panelists a couple of years ago, but it was all on shoulders of one person to organize it and run it, and it became unfeasible. So it took some efforts, but I'm glad for everybody who volunteers to be on the panel and supporting these efforts. And I'm also very happy for all those who are preparing for the exam and taking their career seriously. So that's always good to see this commitment, and we wish you all the success. I've been around in the industry for almost 30 years in operations, in quality assurance. I have my own one-person company, being the boss, the cleaning lady, the secretary, the travel organizer, and all these just in one person, different hats, switching. I still enjoy what I do, and I hope you will keep enjoying what you do, because it has a meaning, it has a purpose, and otherwise it would make no sense. If it was just to earn money, that would not be reason good enough for me, at least. So welcome, everyone.
Okay, Pam.
Yep, got to get myself off mute. Hi, my name is Pam Delia-Geltner. I am an independent consultant also, and really feel that I enjoy doing these types of trainings also. I feel like I learn something each time, and also refreshing my memory perhaps of different processes. Being an independent consultant, a lot of times I don't have a department to bounce ideas off. So sometimes learning new things, questions that people ask that maybe I have not come across before. I feel like every audit is a learning experience. Each one is a little bit different. And I think that's what keeps me going in the industry after over 30 years, probably within clinical research and all different areas. So please don't be shy to ask questions. No question is a stupid question. Only the one that doesn't get asked and answered. So jump in whenever you can.
And Michael.
Hi, I'm Michael Hammerl. I'm a longtime GCP consultant auditor, longtime member of SQA. I've been certified for, I think, about 20 years or something like that. And enjoy participating in these learning sessions and update sessions and the training aspect. So hopefully it can help contribute to those on the call who are getting ready to take the certification exam.
Great. And I want to say, so today I'll go ahead and get started. Let me see if it's going to go forward. I'll just try it this way. Oh, there we go. So let's see if that's how well this will work. So today our focus is communicating, educating, reporting, advising. And I'm so glad that Kamala and Pam and Michael are on to participate in this discussion, because this is where, if you go through the regulations, and ICH E6 and general principles of clinical trials, there's really no specific language. We talk about things should be done, but no, how to do it is not there. And so how we do it in industry really, I think it's not that different, but there's a lot of nuances and sometimes intermittent steps and so I think this is more opportunity for, there are some questions to go through, but I really want you all to ask questions, and particularly if we don't have a sample question that kind of hits on an area that you want to hear people talk about, really put it in chat or just speak out or raise your hand, however you're comfortable doing that, because I really think this is an opportunity to talk through some things. So I went through the GCP, ICH-E6 and CFR. I wanted to see if I put in those terms, what does it say? What do we get from it? And so really in communication, really other than, just talking about our audit reporting, it really talks, in ICH-E6, we have this section about risk and risk communication. And so, the reminder specifically that we've got to communicate quality management activities for those who are involved and affected by the activities, and facilitate risk review and continual improvement during our clinical trial execution. And that type of communication, I think, has many facets. There's an aspect of our the specific QA tasks and the risks we might evaluate or look at, and then our risk activities that is responsibility of our clinical project teams. And we have this escalation and communication of information it could be through like a management review team. I know some groups call it a quality council. I'm one sponsor. We have a GCP committee, but we look at our CAPA metrics, our audit metrics, if CAPAs are remaining open, why are they remaining open? The observations that are being made at our vendors and our sites. So this is a way of communicating these issues through our management team, through our QA hierarchy. And I've used the word, escalation at the bottom. So things, we don't want to identify things, as auditors or as quality assurance. It can't stay with us. It's got to be move out into our project teams. It's got to be elevated to the appropriate management personnel when decisions, actions, investigations is needed. And I wanted to open up to Pam or Kamala or Michael. Do you all have any kind of comments or things you want to add about communication? Just put you on the spot there.
Okay, let me get started. So if you think about communication and education, I would say is a specific part of communication. Escalation, again, is a specific part of communication. Mm-hmm. So you may have been thinking about internal communication within your organization or within your team, within your department, and external communication. You may have other departments in your organization that you are not very often in contact with. They are a kind of external to your typical daily group of people whom you talk to. But then if you are, say, part of a service providing organization, with your clients, your customers, even in the pharma, so many times now there are joint projects, joint clinical trials with multiple sponsors. So here you have also communication perhaps to the QA people in other companies, and not only to QA, and you have communication to auditees. So each type of communication needs kind of certain style. Of course, there is always should be clarity, should be some kind of organized thought process. Just today, I got a message or comments from a client, QA person, and I just kick it back saying, sorry, I can't understand. What do you mean? it made no sense to me. So being very clear, making oneself easy to understand. So that's the key part. So how do we communicate clearly to whom and when and why and what's the message? What's the purpose of the communication? Is it more formal or informal? The way we communicate, the actual vocabulary, if you wish, may either kill the message or support the message. So communication, it's art and skills to be learned. That's just my part.
Okay. And I want to add to, and we'll talk a little bit further, but when we, for exam questions, and I think in this area, that's really when you see, if you see a question in this area that there's not a lot of specific things in ICH or Code of Federal Regulations that say this is what you do, then you really want to apply some logic and common sense. So don't because of that. So don't read too much into it. Probably whatever you see, because this is really when it's like you're not memorizing a regulation or an ICH statement for this. It's really what is the logical common sense answer this question. And so, you might be uneasy, go with your first impulse, flag it, and then go back. This is one of the ones that, go with your impulse, your first thoughts, because they're probably the correct ones, but then you can flag it and go back to it after you've gone through all the other questions. And maybe you'll feel more at ease with how you've answered it after you've finished it. But educating and advising, this is interesting. Because what we know about, what ICH 6, selection and qualification of auditors, our auditors should be qualified by training and experience, and it should be documented. This goes to any personnel involved in a clinical trial, monitors, investigator, research staff. Everyone should be qualified by training and experience, and it has to be documented somewhere. It has to be demonstratable, to us when we go to the site, to a regulator if they were to inspect. So, but how do we incorporate educating our auditees into the audit process? Now, we all, I think, have been challenged and found it necessary to do this. And I don't know if I can speak to how I do it, but I love, our attendees or any of the faculty attendees, you can contribute. You are out there working. So you've probably shared in these experiences. But one thing I found when auditing, you can't, at a vendor or a site, I can't just, or an internal process audit, maybe a peer in a company that I work for, you don't just tell them what they're doing wrong or what they have to do. You're not doing it. You need to have context around it. Ideally, you want to have a standard to cite. It might be a regulation. It might be ICH, a GCP principle. It might be your internal SOP. It might be a site SOP. But putting that around it, I think it makes whatever you're saying much more palatable when you're giving them advice. And in this case, that's not I'm not training them at that point in time. I'm auditing and I'm giving them feedback, or I'm telling them there's a problem, there's a finding, and I want them to know this is why I'm responding in this or bringing this up, because I can't see this, or I've seen this and I consider it a problem, and it's because of this regulatory requirement that is being met or not met, or this SOP requirement, or maybe there's just a gap, something's not being done, and in order, kind of, it's like doesn't hit one of the regulations, but it's probably, if it remains a gap, is going to be a problem. And so, but people are much more receptive when it's not a personal attack. It's just about the documentation and what they needs to be seen in your view. And does anyone want to add, or from anybody, does anyone want to add or comment on this type of situation where you're advising, not formally training? I just really think advising in either context or an audit, or a discussion of an issue with a trial.
For me, it's helping the auditee to understand the consequence if it's not done the way it should be done. It really helps to see not just, this is the regulation and that's the reason. perhaps even if there is no regulation, there is a bigger reason, like participant safety, or one day the general patient population safety. The ability to show that things were done properly, and so helping to understand why we want something, why we point out something, and what happens if it's not fulfilled. That typically helps to achieve better compliance.
Was someone else going to speak? Just
I have to agree 100%. Just thinking about an audit I just conducted, it was amazing what the site did not know. And, pointing out the regulation or the guidance or the SOP, as Jenny had noted, and then telling them how do they meet that, or how have they not met that, and why that's important. And it was a very much of a teaching moment, not as a regular training course, but also letting them know where they can find information about some of the regulations, asking the IRB about this question or that question. Don't be afraid to do that. And I think that and I've always said this, by seeing something that goes wrong at a site, a lot of times you can then identify that at a later time at maybe another site or another audit. So you're almost teaching yourself also different, until this occurs, you don't realize maybe the consequences of it. But once it occurs, then as you start, looking into it deeper and deeper, you're like, this is how this affects this, that affects this, that affects this. And so having some of that insight is really good too.
thanks, Pam. So then I was just going to talk briefly about reporting before we get into our just some sample questions, which I know everyone wants to go through those. But so types of reporting there for QA, there's our standard. There's just our reports we write. We have for our internal or systems audits, our vendor audits, our investigational site audits. But then we have that reporting of quality metrics that we might be required, or we should be doing, but there might be a structure around it within our organization for reporting our audit metrics to management. I mentioned the management review or the quality council, our CAPAs resulting from audits, or if you have a quality event process, you sometimes have you identify something significant event that requires a corrective and preventive action, and then maybe notifying the FDA if you're terminating an investigator's participation. And I mentioned this one simply because I think QA is an integral part of that, because generally we've audited the site and we've been part of documenting what was happening to make sure that we have everything as a sponsor we need to have in place before we take this step to terminate and then notify the FDA. And then I didn't want to leave out devices. To be honest, I'm not a device person. I took the exam so long ago that I don't remember the questions that were on the exam, but I thought we want to make sure, in the device arena, there are actually some specific requirements. In reporting, there's a management representative reporting on the performance of the quality system. It does specify with devices too, in that reporting process, you need to make, you have to have audit reports reviewed and signed off by management, whereas we don't necessarily require that in GCP. Of course, nothing's required in F2Gov by the Code of Federal Relations and Regulations in GCP, but that there are specific requirements. Does anybody recall on the call? Camilla or Michael or Pam, it's devices, an area that a lot of questions come from for the quality system, or is it really just purely GCP, ICH kind of stuff?
There are a few questions, if I remember, that are somewhat directed towards the subtle differences between drug and device, but most of them are about GCP and audits in general.
Okay. Great. Thank you so much, Michael. Because I don't want to alarm people, but I don't want to neglect mentioning an area.
Yeah, because if you think about devices, then actually ICH E6 does not apply for clinical
Yes.
trials
Yeah.
for devices.
Yeah.
It's ISO 14155, which is the GCP for device studies. And many things are similar, but some terminology is different. There are some additional things because like in device, you have like the device malfunction, which you do not see in drug studies. You have additional risks, you have additional components, what needs to be looked at. So there are a few differences. And one more thing for the previous slide, your support might be needed to help with answers to FDA observations. And this is very important since, one, there is a very short time. Typically, you have 2 weeks to submit the answers. It needs to have supportive evidence. So it's not just vague, we will consider doing this or doing that, but this is the plan. We have already started implementing it, or we have already this kind of result, let's say draft SOP or under review, whatever. So be very specific, to the point, to make the answers accepted, because that's the only way to avoid a warning letter. Warning letter goes in a case that the answers are found unacceptable, insufficient, too vague. So this is something where your expertise would be very much valuable.
Right. Thanks. So did anyone want to comment or have any questions about kind of some of this area we've talked about, kind of in general about reporting, advising, educating? I haven't really talked about, educating is I think, in everything we do in all of our conversations, I think with our stakeholders in clinical operations and at the sites, I talked about advising, during an audit and giving the context around a finding, but there's always that, I think, that ongoing educational component, where we, talk with them about why we're asking the questions we're asking. We want to make sure there's no gaps in a process or regulatory requirements are being met through their approach and documentation process.
I think just to mention something about devices, probably to read over just the 820, not memorizing it, but especially if you don't work with devices, and I have to admit I do not, but I didn't even know what the terminology was or anything. So that actually just helped to kind of get that terminology in my mind if it's a little bit different, or, maybe as reading through it going, what's a little bit different than GCP for drug? And, that's probably all you really need to do. I mean, if you're a device expert, that's great. But I don't think, I'm trying to remember, I don't think there's, maybe one, two questions if they pop up, because there is a whole selection of questions. So depending on what gets pulled on from the bank into actual test.
Great. Thank you, Pam. Yeah, I realized, I don't know if I took the rack and are close, fairly close, within a couple of years. I wonder if I'm thinking of the rack when I think of a question. So here's some sample question. Let's see all. Populate your answer in chat before we discuss the answer.
Jenny, you might want to take yourself off video. You were
Chat
breaking.
yet.
I'm not sure if it was you or me.
It's probably me. I'm going to have to stop, go out of share. I see a couple people have responded.
There we go. We have you back. It might have been part of me too.
I had the same thing, so it's,
No, I think it's, I, I think it's me. In my area, the last couple weeks, there's been problems. So yeah, so I'll go ahead and speak everyone through. They should not ask for it. They should be asking for audit certificates. I just had a client email me this week because they clearly did not keep track of the audit certificates I had provided, so I was providing more. So in general, if you look at CFR, it's going to, or GCP, they'll say that they would not ask for reports, but they would ask for audit certificates.
Yeah, another area that I had a client that they don't do audit certificates, but they be sharing in the CSRs that they list all the audits. And so they pull that information out and put it in their TMF for audits that are conducted for the study. So there might be other areas of documentation of their audits.
yeah, there is an exception when
Okay.
the inspectors can ask for audit reports, and that's for their for-cause inspections. So there has been either a whistleblower raising alarm that something there might be a fraud or something, or the regulators themselves. That typically happens at the time of marketing authorization. They go through the data and they see some anomaly, something strange, and they decide to go and do a for-cause inspection. In that case, they may ask for audit reports if those sites were audited. But routinely, it's not done. It's not done. But they still want to see some kind of reasonable evidence, which is not just a memo saying the site was audited, signed by somebody, but some kind of evidence when, by whom, what exactly was the area, and maybe even general outcome of the audit. So some kind of tracker with this information may come in very handy also for the inspections of sponsors.
I see there's a couple of comments put in there that site closure letter serves as evidence and the cover page. So there's different ways to be able to meet that need of documenting the actual audit that occurred.
Yeah, exactly. So now let's talk about risk reporting. The sponsor should describe the quality management approach implemented in the trial and summarize important deviations from the predefined quality tolerance limits and remedial actions taken in the annual audit plan, IND annual report, investigator's brochure, clinical study report. And I see fours. Any other opinion from anyone than four? From the panelists or from anyone from the study group?
That's right. Let's see if I can get the screen to work. It is the clinical study report. And I think that, it's important to, remind teams, when you're supporting a clinical program and you're providing, when these issues arrive, like CAPAs and stuff, I always say, you need to track them, storyboard them, be aware, because you might, want this might be one of the things that really needs to be called out and discussed within your clinical study report.
Now let me ask you a question. I mean, if you can still stay the previous slide, thank you. Quality tolerance limits. Anyone volunteers to say what they are and what they are good for? feel free to unmute and just speak up.
And I see someone also put in, should it also be two, usually not in the annual report. It's usually a data-driven report.
Okay, and I've seen someone
And then
asking,
this,
go ahead, sorry.
no, go ahead. Kamal, you can repeat. I think they need you to repeat your question.
Yeah, exactly. So my question is, what are quality tolerance limits and what they are good for? It's a new thing that came first time in the second revision of GCP in 2016.
And is it not going away in revision 3? I thought that this terminology was not going to be part of revision 3.
No, it stays there, and it's actually I would say augmented by the critical to quality factors.
Really? I know I was at the SQA meeting last year, and maybe it was Christy. I thought someone said this terminology was not going to continue to be used in the, but maybe I misheard what she was saying.
I see here one answer from Notorious saying it's a parameter. Parameter set for the quality of the trial. Basically, yes, it's a parameter or a set of few parameters that define a range where the study results are going to be valid. It's always study level. It's never patient level. So on study level, let's say you have way too many dropouts or breaches of inclusion-exclusion criteria or patients who withdraw consent. And suddenly you end up with a smaller population and the power of your study to interpret the results just drops down. And it may destroy the whole study. It could be also to safety. If it's basically, it's a parameter, then if it's ignored, invalidates the whole study. But we need to remember it's on the study level and it's not on an individual participant level. So that's just the point, because there are still some question marks what QTLs are, what they are good for, how to approach them, especially with smaller companies. They find some challenges because it needs statistician, it needs QA people, it needs someone from medical. It's to define them, it's a teamwork. It's not just a decision of the project manager.
Yeah, and I see someone made I think a good comment regarding if the limit is approached, the team should explore the potential reasons and determine the cause and possible corrective actions.
Yeah, typically it shows there is a systemic problem. It's not just a random error, but there is some kind of systematic issue that can undermine the outcomes of the study.
I think very good conversation, because also thinking, what are predefined quality tolerance limits might help you to answer the question also. And thinking, if you come across this question, you go, I don't know. Think about what they're asking is describing something that was implemented in the trial. So looking at the different types of reporting, which one would be the best one to describe something about the trial? IB, probably not. That's usually just safety data or CMC type of information. IND annual report, that's usually just where studies are and kind of an update. Annual audit report, annual audit plan probably would not have information about what actually happened in the trial. So that's another one you can think about. If it's noting trial, what documentation would be explaining about the trial? And you can always come back to them, as we keep saying, you can mark that question and come back to it, and something else might trigger your memory.
So I was going to let you all read this one. Well, I'll just read it and I'll let you, I'm not going to read the L, but non-compliance with the protocol by this should lead to a prompt action by the sponsor. So which group? I see four. Yep. Let me go back. Yes, it is 4. It's going to be both. A lot of times you're thinking about maybe just the investigator staff, but this could be a member of the sponsor. And then also when we say sponsor, it could mean CRO. So don't forget that. I used the verbiage straight from ICH, but CRO slash sponsor slash CRO in this case, if there is non-compliance occurring, you need to bring them into compliance. And I have had clients bringing me in to audit sites that this was non-compliance in the investigator site that persisted. And so this is prompt. They don't say how quickly things should be brought into compliance, but and we know some things depending on what is happening. And I'm just like, let's say I'm talking about investigator site, what's happening. You can't just turn on a dime and correct something if it's a process related issue, but you have to consider what is reasonable. And I've been sent out to audit a site, and I realized once I got there, this was the client's way of kind of fixing the problem. I hope everyone can hear me. I'm getting a message. I have unstable internet, but they had allowed a problem to persist for 6 months. And it was a serious problem. And so I had to turn around and say, I found a critical finding for this sponsor, this audit, but you've known about this, and you and the CRO, monitors, no one has fixed it. No one has brought the site into compliance. This is a subject, and it was jeopardizing subject. I felt subject safety. So that blurry little word prompt that doesn't tell us how quickly things, there's also then logic of how quick prompt is prompt enough. And so just wanted to throw that out there.
That's an important point you raised, because throughout FDA regulations and guidances, they love to use adverbs like prompt, immediately, consistent, whatever. And they don't define how prompt is, or how immediate is immediate. And it's really up to the sponsor, the CRO, whoever, the site, to have procedures that define how prompt you consider prompt to be.
I would say it should be based on a risk assessment. So if there is an immediate hazard for the participants, for their safety, it should be a top priority. If it's something that would completely ruin the quality of the data, like you find out, for example, that your ECRF is not validated and what is inside is completely unreliable, again, that's top priority. There might be other things that is more subtle, and you would say this is not so critical, but again, you should not leave it for time indefinite. So there should be quite clear timeline depending on the risk level, depending on the impact assessment, and how fast should it be done. And the sponsor is responsible. If the compliance cannot be achieved, terminate the site, as simple as that, and report it to the authorities. So I would say if I am FDA and I see that yes, the site was terminated after 1 year or 1 year and a half, I would not be happy at all, meaning like after identifying an issue, why did you leave it for such a long time? Because something that starts smaller, you know, you may have this snowball effect and it turns out into a disaster. So again, being clear about the timelines and again, using common sense and always keeping in mind the safety of the participants and the quality of the data. These are the two most important things, plus regulatory compliance.
So this is just a rather straightforward one about the education / training of our auditors. Got an A and an A.
Okay.
We'll get a couple more review responses from you, and then I'll.
Any other opinion than A?
Yeah, we see a D. Someone is, and a second D. I will go ahead and move this forward, and it is D. So I tried to get a little tricky. Qualified by observing a mentor. I think mentors are excellent. And I do think, on the job training in which you have an opportunity to observe someone who is more, the expert at a skill set you are expanding into or were developing, training in is great. But that is not going to be what they want to audit. This is strictly from GCP. They want to be, you want someone independent of the clinical trial systems, but you need to be trained, qualified by training and experience, and not just. So I was literally just making that one a little more of a muddy one to answer, because there are those questions there that so I made it so that you had, if you knew GCP 1 and 4 are absolute. And so I try to make it so that you could kind of figure out a way to eliminate answers and get to D if you had, needed to do that.
And on the top of that, if you think about 2, qualified by observing a mentor, it means that the auditor is observing the mentor. Okay, so what it means in terms of qualification.
Yes.
If the auditor is mentee and the mentor gives a very positive opinion, that's a different story. But what kind of qualification is it if I am observing a mentor?
Yeah, your mentor may not be have the expertise and the what you're training for. Our mentors come from a lot of different spaces, and they might be someone in higher in management, and they're far removed actually from auditing, so they might not be the best person. So reporting. So you have your clinical QA department should have written procedures that describe the following. Oop, I was rushing when I wrote this one because I just saw a problem with this question, but.
And we have these and these and these.
Yeah, so I don't know what I was, all of the above. Yeah, I think I was thinking, I don't know, yes, D is the same as 3. Yeah, I did get audit planning, and audit planning should not have been both there, but it is definitely still all of the above. So a sponsor should periodically review risk, and this is GCP, periodically review risk control measures at the following frequency.
So at least annually, biannually, according to the written procedure, every 6 months. Leave it up to the individual project teams. I see one. Let's see. Preferred answer. I don't see any other answers coming. 3. Uh, 33.
3. I think sure.
It's like voting twice for number 3. That's
Yes.
how I understand it.
Yes. And I think this is also another muddy one because risk review, you know, if you're involved or have are able to be involved with a project team on a regular basis, you'll see that it should be an ongoing activity but that's not what's listed here. So if that's not an option here, yeah. So risk should be at top of the mind, yes. And you're never not thinking about risk, but I will go ahead and share. I put according to the written procedure, and this is my answer because this is what GCP says is the sponsor should periodically review risk control measures. And they don't say, again, this is where Michael and I were talking about, they don't give specifics about how frequently. So if you're formalizing this process, so project teams are going to have their risk log, they're going to have their risk plan, they're going to have ways that they're observing it. But if I saw this question, I kind of would go to what is the most logical thing. There's nothing that says it has to be annually or biannually in GCP or a regulation. Yeah, you don't want to leave it up to the project team because some will be really on top of it and some will, you know, avoid looking at it. And so you've got to have, you know, to me, this is one of the common sense answers. What's the written procedure? Hopefully it's adequate procedure, but so I hope you don't mind these kind of muddy ones I'm putting in there, but I'm like, yeah, so the SOP could say 3 years. And so you could have a regulator come in and find fault with your procedures because they're inadequate to allow you to provide oversight to the risks.
A typical SOP would for some flexibility. Again, risk proportionate and risk-based approach. So not every risk deserves the same attention. And we may group the control measures. So there should be some kind of advice in the SOP, maybe a table saying, for this, you need to review that frequently, for this, that frequently. And I've seen clients, pharma companies, and they say that they're critical GXP vendors should be audited every 5 years. I am not convinced it's good. I would say the time should be shorter because 5 years is a really long time. Here, if you think about study risk control measures, then really it depends. Is it observational? Is it interventional? Is it a known product? Is it IND? Is the study going to last 10 years? Or is it phase 1? Everything is really packed. So you would decide as it fits the particular study. If we talk now about the clinical risk control measure and not just a risk control measure, which can be related to vendors, for example. So it should be tailored. It should be fit for purpose. I don't need to do it too frequently for an observational study that's planned for 12 years. But I should do it, I would say monthly. If it's IND, phase 3, my pivotal study, and I'm going to submit the data for the marketing authorization.
So oh, I'm sorry.
No, go ahead.
Yeah, I was looking at a question. I think this is a good question that someone has asked. If this was a test question, how would you have answered? So Kamala, Michael, and Pam, would you have picked something different than 3?
No, because it's the procedure that should define the approach. There is nothing rigid.
Mm-hmm. Okay.
No, I think you have to go with based on your written procedure, because every company, every project has different risk considerations. And so the frequency depends on the risk. And for a long-term longitudinal observational study, maybe you only have to do it every couple of years. So, you need a written procedure.
Yeah. And I think, as we were saying, a lot of these questions, I was, you're going to read it and go, I feel really comfortable. 3 is it, and go with that. But, and then the questions, as we've, reiterated over and over, there are some that you're going to have to read a few times, and maybe you're going to read it a few times because you're reading so fast, you're skipping over the key word, like not, or something that, you have to, you read it more slowly and go, okay, oh, now it's obvious. I don't know why I was trying to rush. But there are questions like that. Go with the, with your gut, I think, when you're kind of a little, if it's not, it's something you have to think over, go with your gut. But let me see.
Yeah, I saw a comment saying that was my first feeling, but then I thought it was a trick. So then we oversmart ourselves.
So I thought I checked all of it and I gave the answer at the bottom, but but this was another one of, I wanted to just say that I actually had this come up in a training someone was giving this week, that they found out, someone observed, is actually not the auditor, but it was data management, figured out through looking at data that a subject was being overdosed. And this is a pediatric study. And the monitor had never caught it. And so this is really wanted to think about as an auditor, at the site. You don't, you're not gonna, you want to inform immediately when you find something like that. This is, you need to inform escalate it to the PI immediately, make sure, and also because you want to make sure that you've interpreted that data, what you're looking at, correctly. You've looked at that looks like a no overdosing situation. Sit down with that data immediately and with the PI and make sure that they concur. But then you need to escalate it. And you might have to escalate it in accordance with an existing SOP. And you also you have to consider maybe the specifics of an audit plan for that particular set of audits you're doing. So does everyone, so I would have said 2, 3, and 4. You're not called, now the FDA might ultimately have to be notified for, if it's a safety, and then the site's going to have to notify the IRB. Things will happen, but this is just talking about your actions as quality assurance at a site during an audit, and how do you, what is directing your actions in that scenario. And so Kamala and Michael and Pam, do you guys agree? Or
I do. I saw the opinion D, like 2 and 4, inform the PI, follow the SOP, probably with the thought at the back of the mind that, yeah, the audit plan should not contradict the SOP. So if I choose these 2, I should be okay, but there might be something additional with the audit plan.
Yeah. I was optimistically, oh, go ahead, Michael.
Important to read the question. It's like, what is the auditor should do? And as you pointed out, I mean, eventually someone may need to tell the FDA, but that's not the auditor's job. And so read the questions carefully. What are they asking here? In this case, what's the auditor's actions?
Yeah, because I think the SOP is going to have you describe really, and I think I wrote it this way too. There's the general escalation that might happen that an SOP is going to dictate, but within the context of that plan, you might have specific individuals you're including in that notification that an SOP is not going to have. So now that you're conducting the audit, not only are you going to escalate to your supervisor, because that's what the SOP tells you to do, but then you're escalating to, Jane Doe or Tom Smith as the, the clinical trial lead.
Exactly.
Yeah, have to agree with that. And that's happened quite often. I shouldn't say quite often, but it has happened with something you may think is a critical issue.
Mhm. And so now we're back to where we're actually in a time and that there's no more new questions. The remaining questions on the slide deck are the ones that have been probably covered at earlier sessions. But all of these will be in our faculty library for this session. I'll upload it actually as soon as we're done, just to make sure it's there. And we should be recording. I really hope it didn't stop recording. No, it is still recording. This recording is also available. And so I really appreciate everyone calling in. I see someone's comment about, yeah, maybe the plan doesn't have that kind of guidance, but SOP should spell that out as well. Yeah, so basically you should have that information somewhere. But okay, thank you all so much for calling in. And for those who are signed up to take it, good luck.
Yes.
Have a good rest of the day. Bye-bye.